From Microbe TV, this is Infectious Disease Puscast, episode 56, recorded on June 5th, 2024 at 6 p.m. Hello, everyone. I'm Daniel Griffin, and joining me today is Sara Dong.
Hi, everyone. I'm Sara. Welcome to another Puscast. References, as always, are available at our show notes at microbe.tv, the home of our growing multimedia empire. I don't have anything prepared today, Daniel. I'm on service, so my usual slight decrease in articles that comes along with that.
No, that's fine. I'm watching one of my dogs try to break into the recording studio. So if you hear a poor cocker spaniel crying in the background, desperate to just be that much closer to his owner, so.
He's really interested in ID literature.
That's what it was. He did not care until he heard the intro.
Well, Puscast is a review of the infectious disease literature for the last 2 weeks that we found interesting or entertaining. So on to the literature, shall we?
All right, we will start off with viral, and remember to listen to This Week in Virology, both the deep dives and the clinical updates. There's been some good ones recently, actually, and I'm referring to the deep dive, not just, congratulating myself. But yeah, I like the clinical updates too, by the way. A lot of entertaining things, I think, about the bird flu and the dogs and all that stuff. But let's get right into our viral section, the article Development and Field Validation of Reverse Transcription Loop-Mediated Isothermal Amplification Assay, RT-LAMP, for the rapid detection of chikungunya virus in patient and mosquito samples, published in CMI. So very simply, they tested a point of care isothermal, it just stays at one temperature, amplification test for chikungunya viral infection and demonstrate the ability of this RT-LAMP assay to detect the virus in different human specimens, so serum, urine, saliva, and then these crude lysets of Aedes aegypti mosquitoes in as little, you ready for this, 20 to 30 minutes. This is going to work for your generation, Sara, and without a separate RNA isolation step. Lastly, they showed that our RT-LAMP assay could be lyophilized. That's basically where you dry the stuff out and you can reactivate it later by adding some water. Those are like those little brine shrimp that they used to sell or something, the sea monkeys. You lyophilize this just like sea monkeys and boom, comes back to life. You store it at room temperature. So really, it's got a lot of the things you want in a point of care limited resource setting. The RT-LAMP had a clinical sensitivity of, they say 100%, give it a little bit of a range, but pretty close to 100%, clinical specificity of 96.72%, overall accuracy of 98%. This is really what we need. If we're considering chikungunya in the differential, right? Your academic center and you're rattling off your differential as the, I saw a cartoon, as the much too general doctor, and you're thinking of everything. You kind of want to know if it's chikungunya in 20 to 30 minutes, not like a week later when they've gone home and you're like, oh, interesting. So maybe I think of New York City as a limited resource center that could use this as well.
My paper for the viral section is from Transplant Infectious Disease, Adenovirus and Cytomegalovirus Specific Adoptive T-cell Therapy in the Context of Hematologic Cell Transplant or HIV Infection, a Single Center. I would say as an immunocompromised, most of the time ID doc, I feel like discussions on adoptive T-cell therapy have been coming up more and more often as options for the future for patients who have severe viral infection reactivations. Particularly with viruses like adenovirus, where we don't really have a great antiviral option, or we have one that we can try, but it's not so great. So like the title said, this is a single center retrospective experience of 10 adult patients in Germany who were treated with adenovirus or CMV specific T cells over a decade from 2012 to 2022. 4 of those were adenovirus specific, 5 were CMV, and 1 was adenovirus and CMV co-infection. The cells were derived from stem cell donors in 6 out of 10 cases and third-party donors in the remaining 4. These were patients who had underlying heme malignancies, so 4 acute leukemia, 5 non-Hodgkin lymphomas, 1 myeloproliferative neoplasm, and then 8 of these patients had received at least 1 allogeneic stem cell transplant. And then they also just make the point that patient number 10, who had plasmablastic lymphoma, was also living with HIV. Their response criteria was met by 6 patients, which included all of the 4 patients who had adenovirus, 2 of the patients who had CMV, and not the patient who had adeno and CMV co-infection. And they define response as a decrease in the viral load by at least 1 log, or a clear improvement or resolution of signs and symptoms or lab abnormalities. I will point out that all the patients who had adenovirus were also treated with cidofovir. Overall, their survival was only 40% of the group. None of the sort of, quote, non-responding patients survived, but there were no significant infusion-related adverse effects. There was aggravation of GVHD in 2 cases, although it kind of timed up with getting a donor lymphocyte infusion or stem cell boost, so it could be for those reasons. These are tough because I think a lot of the patients often have multiple viral reactivations at once, and it seems like many of these cases did. We're obviously missing a control group, multiple centers, something to help us understand if this is a mix of antiviral or other adjustments they did in their medications. But I also included this because it's a plug for double checking the spelling of your title when you do that final proof of your paper, because the T in transplant in the title was left out. At least on the PDF that I downloaded today, it's still left off. So maybe, I'm sure they'll fix it soon.
Oh, that's hilarious. So I just wanted to ask, with all sensitivity, so you say as an immunocompromised ID doc, so are you sharing that you're immunocompromised, or do you take care of immunocompromised patients?
As in, all my service is patients who are immunocompromised.
Okay. Yeah, because I was just like, okay, I did not know, but okay, just to clarify.
No, that's why.
But no, this is the kind of stuff. This is like this science fiction coming to life. The whole idea about, giving specific T cells, and having them fighting the infection. Just exciting stuff to see how this
I know that there's a lot of trials and such that are open that hopefully we'll get, comparison data, more info. But yeah, I hope that this is something we can work towards. And also the feasibility of being able to get these off the ground and centers and patients having to travel, lots of factors.
And time sensitive, right? Getting them at the time when you need them.
At the time they need it, yeah. Great. Okay, so for the bacterial section, be sure to listen to This Week in Microbiology. I think melioidosis is fascinating, so I pulled this article. Melioidosis, an activation from latency. The, quote, time bomb has not occurred, from the American Journal of Tropical Medicine and Hygiene. Burkholderia pseudomallei, the agent of melioidosis, has been considered able to exist in latent form. And I learned this, I didn't know, that I guess this seropositivity for melioidosis among U.S. soldiers returning from the Vietnam conflict at some point led to the dub of, quote, Vietnamese time bomb, and I don't like that, so I will use time bomb disease instead. But basically, this paper is taking a look at latency from reviewing cases in the Darwin, as in the Northern Australia Darwin prospective melioidosis study, as well as other reported historical cases. The longest plausible duration of asymptomatic latency remains 29 years. But their overall take-home message here is that activation from latency is rare and accounted for less than 3% of at least the cases in that Darwin study group. And then I put the quote here, consistent with why the time bomb never eventuated. So the vast majority of patients who are going to be having melioidosis are going to have had recent infection and present with acute disease, with many of those patients who are really sick being bacteremic. And so I think the point is that framework, that like true reactivation disease from a really remote asymptomatic infection is super uncommon. And they actually, looking back, recategorize some of the ones that were sort of labeled activation from latency as more accurately probably chronic disease that was initially undiagnosed melioidosis, because you can have that sort of relapsing, remitting type sort of persistent chronic infection. And I think a lot of those patients maybe got like short courses of antibiotics and sort of a late diagnosis. And the only other thing I'll point out, they pulled out some triggers for possible for the melioidosis. It seemed like corticosteroids and then intercurrent infections like flu and COVID were common. So one of the authors, Dr. Barclay, was on Febrile, and we did an episode on melioidosis, which I loved, and it's really great, so people can listen to that. But I thought this was really cool. I think if you saw a patient that traveled to an area that melioidosis is endemic, but it's really old, like really keeping that on your differential should fall off. We love an ID to say like, oh, they went to that one place like 2 decades ago, but I think in reality, like if they haven't been in a somewhat recent time frame, then maybe it seems like it'd be less likely to make someone sort of acutely ill. But I guess be on the lookout for maybe that chronic misdiagnosed picture if you really think it's like an old latent reactivation.
Yeah, no, this is great, and
it's really cool.
It goes, I'm old enough to remember having been taught this. And actually seen a number of melioidosis cases in Southeast Asia. Actually had a good friend from Darwin who was on this task force, deciding like what the, should you do, one of your cephalosporin based, like a cefepime, or ceftaz versus your carbapenems, because this matters. I remember a case of a young boy in Cambodia, actually, who ended up dying of melioidosis because he was on ceftriaxone and the antibiotics were never extended. It really wasn't considered. And that's sort of why. But yeah, I remember this Vietnamese time bomb nickname, and the idea that it was sort of like tuberculosis, that you got it and 10% would reactivate at some point. Really not panning out here. So
yeah, it's nice in the discussion. They kind of touch on that, like all these comparisons to TB and how we can sort of think about it a little bit differently, even though there's similarities.
Yeah. I mean, it does take a little while for the fever to break, right? So this isn't like a normal pneumonia where they're afebrile in 48 hours. It could be a week or two before the fever breaks. But yeah, nice to see a little science instead of just some stories bantered about. All right. Cases of meningococcal disease associated with travel to Saudi Arabia for Umrah pilgrimage, United States, United Kingdom, and France, 2024, MMWR early release. So first, a little reminder that invasive meningococcal disease caused by infection with the bacterium Neisseria meningitidis usually manifests as meningitis or septicemia and can be severe and life-threatening. Actually, sort of amazing how rapid and fulminant the presentations can be, even in a young, healthy individual. Now, 6 serotypes, A, B, C, W, X, and Y. There'll be a test. Actually, there will be a test for some of our listeners. Account for most cases. Asymptomatic persons can carry N. meningitidis and transmit the bacteria to others, potentially causing illness among susceptible persons. So where did I get this? You got it from someone else. Outbreaks can occur in conjunction with large gatherings, famously, such as the Hajj and the Umrah pilgrimages. So what are those? Well, these are pilgrimages to Mecca, and the Hajj occurs each year at a particular time, while the Umrah pilgrimage you can complete any time of the year. Any Muslims with more information, do email us. I always love to get those sort of, maybe you've been on one of these pilgrimages. Love to hear your stories, because I just sort of picture these, masses of humanity, right? Now, vaccines are available to prevent meningococcal disease. Also, antibiotic prophylaxis for close contacts of infected persons is critical in preventing secondary cases. So you want to keep that in mind. Like one case of meningitis can be a whole, infection control challenge. Well, we read here that these pilgrimages involve people from 184 countries in 2024. 30 million pilgrims performed Umrah during the month of Ramadan. Approximately 13.5 million were international travelers. Now, Saudi Arabia has required documentation of either a quadrivalent meningococcal polysaccharide vaccine within the last 3 years, or the ACWY conjugate vaccine within the last 5 years, and administered at least more than 10 days before arrival, right? Got to give it time to start to work, in all the pilgrims who are, you ready for this, 1 year or older entering the country. However, enforcing this requirement is certainly challenging, particularly with Umrah, right? Because it can occur any time of the year. Many pilgrims are not traveling on an Umrah-specific visa, so we can ask everyone who comes in. One study estimated that vaccination compliance for Umrah, because of these variables, is only about 41%. Most people are not doing it, right? Now, 12 meningococcal disease cases associated with Umrah travel to Saudi Arabia were identified. 9 patients were unvaccinated. The vaccination status of 3 were unknown, right? So we don't have any confirmed unvaccinated. Cipro-resistant strains were identified in 3 of the 11 cases, where they had the available antimicrobial susceptibility testing data. So you're really doubling down. You want to get those vaccines, particularly when we're seeing that these strains might actually be resistant to some of our antibiotics.
Yeah, interesting. I think at some point I pulled I feel like one of the old podcasts we had a review too of a lot of this. Great. Okay, so
keep plugging Febrile. I've been enjoying them, and in the middle
I haven't done a Febrile
in the middle of the Febrile Go Green ID sustainability. What is it? Mm-hmm. What is the latest one?
Mm-hmm. Sustainability. Yeah,
it's good stuff so far.
Awesome. Yeah. Well, this next one I pulled from the Journal of Bone and Joint Infection, Dosing and Treatment Duration of Suppressive Antimicrobial Therapy in Orthopedic Implant Infections, a Cohort Study. So this is a retrospective observational study from the Netherlands where they included adult patients on chronic suppressive antimicrobial therapy, or SAT. They described that their standard management of orthopedic implant infections is multidisciplinary, surgical debridement unless there is a contraindication or patient refusal, and then 1 to 2 weeks of IV, followed by 4 to 11 weeks of targeted oral therapy. So big picture, total duration of 6 to 12 weeks of antibiotics. And then they sort of, as a multidisciplinary team, make a decision on whether or not to use SAT, suppressive therapy. So to define what they use, at least in the paper, SAT was defined as prolonged oral antibiotics after that initial standard treatment window, so that first 12 weeks, or plus or minus. And then they actually shared some of their dosing schedules in Table 1. And what's interesting is they actually broke it into what was their standard dosing versus low dosing of the different antibiotic options. So you can take a peek at that on Table 1. And then they also had gone through and used different indications for suppressive therapy. One group that they called certain relapse. So patients with implant infections that didn't get surgery, had late chronic infection managed with DARE, or acute infection with failure of DARE. But the other group they called high risk of relapse, meaning early post-op or acute hematogenous orthopedic infections treated with DARE, and then patients who had risk factors for relapse like previous failures, comorbidities, specific organisms like Candida. And then failure, they defined as appearance or persistence of a fistula, unplanned surgical intervention, or admission for IV antibiotics. If they increased from the low dosage suppressive to standard dosing suppressive antibiotics, if they restarted sort of therapeutic antibiotics after these suppressive agents, uncontrolled symptoms, and of course mortality. And so there were 108 patients in here. They were followed for a median time frame of 21 months. There's a pretty similar amount of hips and knees. There is about 28% hips, 28% knees, and then the rest sort of upper extremity. And then a little over half were prosthetic joints, so versus tumor endoprosthesis or spinal implants, for example. And then for bugs, about a third were staph, about a third were coag-negative staph, and the rest is kind of a hodgepodge of other things. I thought it was interesting to see what people actually use. So they have some images of that, and one of them they split up as the drug that they used and whether or not it was the standard or low dosage. But basically, the take home is that most people use beta-lactams at the lower dosage, and then the sort of next most common was lower dosage of Clinda, which I feel like we try not to use a ton of here. So their overall, quote, success rate with the suppressive therapy in the study was 69%. And then when they kind of broke it down by those who had low dosage of the suppressive antibiotics to those who had standard dose, patients did about the same. And then they had a small group, well, not small, I guess I should say, like almost a quarter, 25 of the 108 patients actually stopped their suppressive therapy in some window of approximately 2 to 3 years. And for what it's worth, those patients had a low relapse rate. So it still doesn't necessarily answer our questions about like exactly how to do suppressive therapy, but I think it's nice to have a little bit of information and see and think about like how do you collect it. And I think maybe one of the motivations for the authors is to reinforce, hey, we often use these lower dose antibiotics just based on we think it's the right thing to do and there's a lower burden, but here's some evidence that says those patients seem to do just as well as if we gave them a more frequent dosing of their Amox or whatever other drug they're on. So pretty cool. And then I pulled one other paper just more as like a quick note or update that was also from MMWR, the CDC clinical guidelines on the use of doxycycline post-exposure prophylaxis for bacterial sexually transmitted infection prevention, US 2024. So this is, to sum it up, CDC's recommending the use of doxypep for MSM and transgender women who have had a bacterial STI diagnosed in the past 12 months, do shared decision-making, and the prescription for doxycycline is 200 milligrams within 72 hours of oral, vaginal, or anal sex, and that this would ideally be implemented in the context, of comprehensive sexual care. But I think exciting, and a lot of people I saw sharing this and being excited to see the CDC endorsing doxypep for our patients. Pretty cool.
Yeah, we had a presentation, and we do these morning conferences at Columbia. And this was a little while back, so I was like zoomed in or something. And it was this whole discussion about, sort of the frequency of, people, how often do people have sex and how often might this happen? And it's sort of, this whole discussion, like, are there concerns that we might end up with drug resistance, right? And are we going to get drug resistance, particularly in this population that might have a lot of sexual networks, right? And so then you end up potentially with a doxy-resistant organism. So, but we're seeing here the CDC has really sort of thought this through, and they're getting on board with this. It was a little embarrassing for me because I think someone, we were talking about like tick bites versus sex, and one of the attendings made the comment, well, I wonder what is more common. And I was like, I think on Long Island it's tick bites, but apparently they were only joking, and I thought they were serious, but so I was being serious. But anyway, okay.
I will not comment on that.
All right. Yeah. It's always good to share stories that make you look bad. Yes. All right. Okay. All right. Fungal. Be sure to watch The Last of Us. I'm gonna start leaving in links to all the shows now, Sarah. So I left in a link to the Wikipedia page. But the article, lower 1,3 beta-D glucan sensitivity and in vitro levels in Candida auris and Candida parapsilosis strains, published in CMI. It's actually open access. I was surprised. And so my thought is that perhaps the crew of the TV series The Last of Us, including Pedro Pascal and Bella Ramsey, may be funding this to drive up interest in scary fungi prior to the release of season 2. So, as mentioned, we're going to start leaving in a link to the Wikipedia page. A little background. The serum 1,3 beta D glucan, BDG assay, because we needed another 3-letter acronym, gives quicker results and has higher sensitivity than blood cultures. Therefore, it is advised for early diagnosis of invasive candidemia and or discontinuation of empirical therapy. In this study, 22 C. auris, 14 C. albicans, and 10 C. piperacillin strains were included. The median BDG levels in supernatants were 463 for C. auris, 1,080 for C. albicans, and 755 for P. piperacillin. So median serum BDG levels were significantly lower in cases of C. auris. I mean, dramatically lower C. auris, a little bit lower in C. piperacillin, much lower, right, than the C. albicans. It was over 1,000. So the sensitivity, right, that's what we're focused on here. Sensitivity of the serum BDG was 39% in the case of C. auris, 30% for P. piperacillin, 78% for C. candidemia. So, I don't know how well this test would work, if these people get infected with the fungi in The Last of Us, but I definitely want a much higher sensitivity.
I wonder why it would be less useful in Candida auris. Like what the mechanism. I mean, I guess you could argue how useful beta D glucan is.
You would always argue that it's useless, but you're seeing here a 78% sensitivity. I'm worried about the sensitivity in cordyceps, but I think the mechanism is the amount of the beta D glucan basically the outside of the organism and how much ends up getting shed. So, different fungi have different levels of this. So I think that's what corresponds to the BDG. Yeah. I mean, 78% sensitivity for candidemia, that's like a C. If you're getting a C on your test, you're not ending up in medical school. I
think there's probably plenty of people who would rank the utility of a glucan lower than a C.
So I know you would. And for C. auris, right?
It has a time and a place. It's just there's very few places and times. Awesome. Well, okay. My fungal paper is called Auto-Brewery Syndrome in a 50-year-old Woman, published in the Canadian Medical Association Journal. This shares a case of a woman who had multiple presentations with alcohol intoxication without any preceding alcohol consumption. So, not surprisingly, I think a lot of people presume that maybe the history was not accurate. So she had lots of evaluations and visits to care, including psychiatric care. And then, in addition to that, she often had lethargy and somnolence that extended beyond those care visits. And then eventually, one of her astute ED physicians considered Auto-Brewery syndrome, prescribed her oral fluconazole, and referred her to GI. And then later, she also met some ID docs. So she did improve with a low-carb diet and fluconazole, and then had recurrent symptoms in the setting of increasing her carb intake. In addition to her fluconazole courses, she was placed on some probiotics to help with gut dysbiosis. And appropriate feedback was given to some of her other care team just about like making sure that if we're treating UTIs, we're using narrow spectrum. And of course, I'm sure it had to do with like guidance on making sure we're not over treating asymptomatic bacteria. But Auto-Brewery syndrome, if you have not, learned about this by reading, are less civilized, like I guess I am. There's a Grey's Anatomy episode on this, and I actually looked it up because I couldn't remember the details. But there is a patient, Dave Buckley, a high school teacher who passed out and pushed a child accidentally into like a handsaw, and then he amputated some of his fingers. And he's like, I don't drink. And everyone's like, no, that teacher's just drunk. Anywho, if you want, that was basically very similar to what this case scenario was, but obviously glamorized for Grey's Anatomy. So if you want to look it up, I don't remember what episode it is, but I'm sure there's only one episode on Auto-Brewery and Grey's Anatomy. So this is a rare syndrome of endogenous alcohol fermentation. So microorganisms capable of fermenting alcohol from carbs outgrow the normal gut flora. And so it's quite uncommon because I think there probably need to be several factors that contribute to that overpopulation of fermenting microorganisms. Patients have to have that high carb consumption that those organisms can break down and turn into alcohol. And it seems like often, their patients might have comorbidities of other medical problems. Some of the commonly implicated fungi include Saccharomyces cerevisiae, oops, I put a B instead of a V, and Candida species, as well as some other bacteria. You, like in this patient's case, really need someone to have a clinical suspicion to diagnosis, and there are some protocols for glucose challenges to test the hypothesis. And then you can get fungal and bacterial cultures of GI secretions from an EGD or a colonoscopy, but that yield is obviously impacted by whether or not that patient has gotten empiric antifungals or antibiotics. So I believe in this case, their GI cultures didn't actually identify certain predominant organisms. It seems like there's a pretty wide range of durations that people will use, but they'll generally treat, it seems like with fluconazole, from anywhere from 3 weeks to maybe 6 to 8 weeks. So fortunately, this patient was diagnosed and plugged into care, but super interesting, and then gave me a reason to reference Grey's Anatomy. So win-win. Patient's better.
Wow. I put in a link to the Grey's Anatomy season 15, episode 3, Gut Feeling.
Oh, excellent title.
Yeah. What I've got to find is, I don't know if you ever watch Dr. Mike Reacts to, and so we've got to send this to Dr. Mike and then have Dr. Mike react and see what he has to say. So
okay. That seems more feasible than getting Pedro.
All right. Parasitic. Be sure to listen to This Week in Parasitism. The article, Subclinical Inflammation in Asymptomatic School Children with Plasmodium falciparum. Parasitemia correlates with impaired cognition, published in JPIDS. It's a really important, I'm going to say it's an important article. And articles like this should not be behind a paywall, as I think the implications are literally global. All right, off my soapbox. In this study, the investigators enrolled 240 children aged 7 to 14 years old residing in high malaria transmission area, Western Kenya. The children performed 5 fluid cognition tests. Basically, they're checking their cognition with these tests. A culturally adapted NIH toolbox and provided blood samples for blood smears and laboratory testing. They're going to look at parasite densities, plasma concentrations of 14 cytokines, and basically they're going to see, is there a correlation here between any of this stuff and the cognitive stuff? So plasma concentrations of TNF, IL-6, IL-8, and IL-10 negatively correlated with the composite score and at least one of the individual composite cognitive tests. Parasite density in parasitemic children negatively correlated with the composite score and the measures of cognitive flexibility and attention. So basically, the higher the parasitemia, the more impact the lower cognitive composite scores. So lots more to look into here. One is how significant, right? So you're seeing these changes, but how much are those going to actually impact activities of daily living? How much they can impact school performance? And does this last into adulthood, right? I mean, are these permanent cognitive impacts, or is this just sort of one moment in time? And then the other thing we always have to be really careful is, so if we step in and intervene, can we then demonstrate, that we're going to see a positive impact? So really, really, I think important. Just think about how many millions of children are at risk, how many millions of children are impacted, and really to impact a child's cognitive ability. This is a priority.
Yeah. And I actually have a second paper from the American Journal of Tropical Medicine and Hygiene, Clinical Characteristics and Outcomes of Disseminated Strongyloidiasis in the U.S., a multi-center network analysis. So, as the title mentioned, this is a U.S.-based multi-center retrospective cohort study to look at the 90-day clinical outcomes of people diagnosed with strongy infection from the TriNetX patient database, which sounds like it's a global research network, specifically hoping to leverage like things that are less frequently encountered in ID. So of 5,434 patients identified with strongyloides infection, 48 had disseminated disease, so that would be a 0.9% prevalence. Some of the comorbidities noted in those patients with disseminated disease included systemic connective tissue disorders, cirrhosis, blood or hematologic disorders, malnutrition, alcohol use, and then receipt of a transplant in the past. Mortality in those with disseminated disease at 30 days was 21%. And I think not surprisingly, patients with disseminated disease had an increased risk of hospitalization, bacteremia, ARDS, and mortality. About 3/4 of those patients required hospitalization. Meaning patients with disseminated disease. So I thought this was cool, kind of giving some insight into how often we actually see disseminated strongy in the U.S.
All right. Only 2 more to go. Hang in there. We have the article, Tafenoquine for Relapsing Babesiosis, a case series published in CID. So just a report of 5 cases, so very much preliminary. But here we read a report of 5 cases of relapsing babesiosis treated with tafenoquine. Including the previous case, and begin to define the conditions for optimal use of tafenoquine in relapsing babesiosis. So they go ahead and they give tafenoquine a loading dose of 600 milligrams, a weekly maintenance dose of 200 or 300 milligrams. Now, the lower dose was associated with a delayed clearance of babesia, right? So maybe 300 is a little bit better here. In 2 cases, all antimicrobial agents but tafenoquine were discontinued prior to clearance of infection. In 2 other cases, clearance was achieved while tafenoquine was administered along with other antimicrobial agents. In 3 of these 4 cases, tafenoquine was used in combination with atovaquone proguanil. Other agents included atovaquone, azithro, and/or clindamycin. And in 1 case, tafenoquine was administered alone and failed to prevent relapse. So, how are they ascertaining? And I thought this was interesting. How do you ascertain clearance? They're doing real-time PCR and they're doing blood smear. So, PCR is a pretty high standard. So I just thought this was interesting when you've got one of these patients, they're relapsing, you're not sure what to do. I have to say, it seems like a reasonable thing to try. I guess my takeaway from this, I probably would use tafenoquine not as monotherapy, but probably in combination with one of these other agents. Mm-hmm. And we are seeing more and more babesia, so more and more relevant.
Babesia.
All
North American malaria.
All right, miscellaneous. So I'll just leave in a random link to anything. No, it's a joke. The article, Integrating Medical Librarians into Infectious Disease Rounding Teams, Survey Results from a Pilot Implementation Study, published in Open Forum Infectious Disease. Now, I will admit they had me at the title. The wheels started spinning, and I was thinking, just what a great idea this is for an academic training center. My next question was, who's going to pay for this? But let us table that one while we review the paper. So this is a quasi-experimental, exploratory pilot implementation study. The evidence-based practice being implemented was reviews of primary medical literature by incorporating a medical librarian into ID specialty-specific rounding team. So, if you're picturing Grey's Anatomy or Dr. House, you got the team there, and among the team is someone with this stereotyped look of a medical librarian. The need, benefits, feasibility, and acceptability of incorporating a medical librarian into ID specialty service rounds was assessed with pre- and post-rounding surveys. Kind of would have rather seen some impact on quality of care, but basically just asking folks what you think. Now, a librarian rounded with the team and used an iPad and cell phone to conduct literature searches for the team as questions arose. This is modeled on previous work. Now, when possible, the librarian searched in real time at the point of care. For in-depth questions, the librarian returned to They say her office, a little bit of, I don't know, I guess they only had ladies, her office, to complete same-day literature searches and report back to the team. I kind of feel like it would have been a little bit better. I'm just thinking of the scenario if they had a rounding little table with a keyboard. I'm just figuring them pen typing away a little faster with a proper keyboard. But the rounding process and duration were highly dependent on the attending physician. Imagine that.
Never a truer sentence.
Yeah. It's like, when we gave antibiotics for a shorter period of time, patients got a shorter period of time of antibiotics. Like, yes. We've all experienced. Who's our attending today? Oh. Didn't make any plans after this. So some attendings had sit-down rounds. Others rounded outside patient rooms. Kind of like, where's that? Like, I like to go in the room, stand at the bedside. Like, where was the Osler rounds? But anyway, the post-rounding surveys indicated that participants felt having a librarian on their medical team rounding improved their ability to find answers to clinical questions and provided them with more satisfying responses. Participants also deemed that the presence of a medical librarian made them more likely to ask for information from the current literature. All responses indicated that the medical librarian followed up to close gaps in knowledge identified during rounding. Additionally, participants indicated the addition of a medical librarian facilitated integrating literature searches into the workflow. Now, it may be that integrating medical librarians into rounds can lead to higher quality, current evidence-based care with its attendant reduction in patient stay length and reduced readmissions. And if that is the case, this might make sense financially in a value-based care model. So I may have figured out how this gets paid for.
Now I'm not sure. I swear when maybe I was in residency, we did some, not ID specific, but we had something where we had a librarian on rounds, and I can't remember what the context was, but it was very nice for the reasons kind of you're mentioning. Very cool.
I think it would just make it like safer to ask questions, because then you feel like, oh, I wonder. And then like, instead of the attending pimping, they could be like, well, let's look it up. And then, you don't end up practicing medicine from 30 years ago or the medicine I remember off the top of my head on round. You actually get, evidence as opposed to that wonderful evidence-based, rhetorical-based, all that other non-evidence-based stuff that too often goes on.
Yeah, very cool. All right. Well, that brings us to the end of this podcast. As always, the references for this show are available at microbe.tv, the home of our growing multimedia empire.
You can find the Infectious Disease Puscast at Apple Podcasts, microbe.tv/Puscast, or grab it with your favorite podcatcher. We love to get your questions, comments, paper suggestions, so send them to puscast@microbe.tv, or you can just keep sending them straight to me, as people tend to do. If you like what we do, or you just want us to keep doing it, consider supporting the science shows of Microbe TV at microbe.tv/contribute or Parasites Without Borders, and click the donate button.
I'm Sara Dong. You can find me at swindong at Febrile Podcast or at febrilepodcast.com.
I'm Daniel Griffin, and you can find me at Columbia University Irving Medical Center. I'll be rounding again in about a week, and it will be at the bedside, not outside the door or sitting at a table. You can also find me on the podcast This Week in Parasitism and This Week in Virology Clinical Updates. And as always, thank you for this most interesting consultation and allowing us to participate in the care of this most difficult and challenging case. We shall continue to follow along with you. Thank you, and dictation, and goodbye.
Thanks for listening. We'll be back in 2 weeks. Another podcast is infectious.